Hi, Bethwell, can you hear us now? Do we have sound? We're just doing a sound check before we get started. Lydia, can you hear me?
Yep, I can hear you.
Okay, great. Good, people are coming in. We've got nearly 30 participants already in. We are going to get started in 2 minutes time. We're just waiting to confirm that Lucky Boy is able to join us. If he's not able to join us, we will press on. There's a lot of knowledge in this room, and that also gives us a lot of time for question and answers, which is what this session is really about. It's about being able to equip you who are interfacing with the community with the right answers or sufficient answers to be able to answer their concerns around the epidemic, the pandemic, and vaccines. So give us 1 more minute and then we'll get started. So welcome everybody. My name is Ntsiki Mpulo. I lead the communications team at Section 27. And thank you very much for joining this session. We decided that we wanted to do this because we, like everybody in this country, we've been inundated with questions around what this virus is and how it's mutating and what we're going to do in terms of vaccines. So we've gathered 2 people who we think are quite knowledgeable about what is going on in this arena to help us navigate these discussions. So the first presentation will be from Dr. Lydia Ken Cross. She's a health activist, a member of the People's Health Movement. She's a medical doctor and the head of Groote Schuur Hospital's Breast and Endocrine Surgery Unit. She was appointed as the Associate Professor of Surgery at the University of Cape Town in March 2020. As a frontline worker, she has been at the forefront of dealing with this pandemic, and so she has unique insights and has the unique, or I suppose she's uniquely qualified to speak about this thing because she was one of the first to receive the Johnson & Johnson vaccine. And the other person that we have is Marcus Lowe. He is the editor of Spotlight, a South African journal. Marcus Spotlight is a South African journalism center that produces in-depth public interest health journalism. He's previously worked as a health journalist at Media 24 and the head of policy and communications and research at the Treatment Action Campaign. He also holds a master's degree in journalism from the University of Stellenbosch. So thank you very much to both of you for making the time today. In terms of our housekeeping rules, if people can just keep themselves muted while if they're not speaking, we're going to have presentations from Lydia and then from Marcus, and thereafter you'll be able to ask questions and you'll be able to unmute yourself. I'm going to ask Lydia to put on the camera and let's get started. You are muted, Lydia, so if you don't mind,
unmuted, sorry. Hi, Ntsiki. Thanks very much for that kind introduction, and thanks everyone for being on this platform. I'll share what I know, and very happy to engage with some questions. Just to say that I'm also a member of the People's Health Movement, and we've been engaged with some community training around vaccines. And I'm going to take you through some of what we do with community health committee members and health workers. Some of it might be, what you already know, and forgive me if I'm repeating some knowledge, but I'll try and contextualize it, and there may be some new things as well. So I'm going to share my screen. There we go. Good. Okay, good. So I've been asked to talk a little bit about some of how vaccines work, a little bit about my personal experience, and some thoughts on the rollout. And Ntsiki, if I take too long, just stop me, and then we can just engage in discussion. Okay. Good. So I think before we even begin, it's important for us to put into context why we need a vaccine against COVID-19. Why this is absolutely critically important at this moment. So and I'm sure as journalists you all know, and all of us know, that this virus has really devastated many populations across the globe. But when you look at the numbers, it's still quite sobering. So there have been 110 million cases of COVID in the world and 2.5 million deaths, over 2.5 million deaths. And in South Africa, we've had a big epidemic with 1.5 million affected, and the official death toll is over 50,000, but it's important to know that it's likely that that death toll is much higher because our excess death, which is the number of people that have died in the year of 2020 during the pandemic versus the number of people that died a year before, is different by 140,000. That means that those are unexpected deaths that would not normally have occurred. And we think most of those are attributable to COVID-19, possibly some to other illnesses, people who may have not had access to healthcare, but the majority of them are likely to be due to COVID. So our death toll is probably at least 100,000, maybe more. We had one wave in June, July, August, which was, it was new, it was scary, and it was devastating in many communities, but not as big as we thought it might be. And we were just catching our breath when we had the second wave. And the second wave was much worse. It was much worse in numbers, and it was much worse in terms of death. So if you have a look here, this is the mortality or the death figures of the second wave. We're now here at the bottom. And there is a very real possibility of a third wave. Some estimates have been looking at a slight uptick. We never get down to zero with these numbers. We're always 1,000, 2,000 per day in terms of new cases. And the excess deaths are also slightly maybe ticking up. So I think a third wave is coming. How big it will be, we don't know. But the problem is after the third wave, there may even be a fourth wave. Because in terms of what we can do for COVID, we don't have many options. So for any disease, you either need to prevent the disease or you need to treat the disease. And sometimes you need to do both. And for COVID, if you look on the prevention side, at a country level, we tried many things. We locked down the whole country. We had levels 1 to 5, and we know the massive social and economic impact of that. And ultimately, those lockdowns only work for a short time. They're not sustainable, and particularly in South Africa, we're not able to do this safely in terms of the social impact on food and employment and so on. There have been many things we've done as individuals, which we need to continue to do. We've become a mask-wearing nation. We wash our hands. Everyone has sanitizer. Sanitizer used to be something that was just for very pedantic people that wanted clean hands. Now everyone has sanitizer, avoiding crowds and so on. And in communities, a lot has been done. So communities have set up care centers. They've helped with sharing good information. Soup kitchens have been established and so on. At a system level, to defeat COVID, what we really need is a better health system. We need more health promoters and community health workers, and ultimately to promote equity and social justice. And we haven't done that systems change. So on a prevention level, we've done some of the things, but let's be honest, it hasn't been successful, and nowhere in the world have they brought this down really just with prevention. So what about treatment? In terms of treatment for COVID-19, we don't have at the moment a drug that cures this virus. We have drugs that help to get people through the illness, that support them. So things like steroids, blood thinning drugs, of course, oxygen. That's really the mainstay of what we're doing in the hospital to support people. And there are lots of investigations and trials going on for new drugs and repurposing of old drugs. But right at this moment, there is no drug that we can say will cure COVID, that if you have this, we'll give you a drug and you'll be better. So at the moment, we're really caught up in a vicious cycle between lockdowns and opening up. And when we open up, the virus spreads, the hospitals fill up and people die. So the question really is, what's the way out of this cycle? Is there a way out of this cycling in and out of lockdown and death? So we come to here, when does a virus stop really? When does a virus stop affecting a community? So if an individual gets COVID-19 and they recover from COVID-19, they will as an individual become immune to it or be resistant to being infected by COVID again. And that immunity is usually demonstrated in the body through antibodies and also some T cells, but antibodies are really the thing. When 60 to 70% of the whole population has immunity to COVID, in other words, they can resist the virus, that is what we call population or herd immunity. So it's a high percentage of the population that needs to get there. And we know that if we get to population immunity, the virus will stop spreading. So one way to do that is to just wait it out and let the virus spread and get to population immunity. The trouble is that 70% of South Africa equals 40 million people. And if we have a death rate of 1 to 2%, 40 million people affected by COVID-19 will mean about 800,000 deaths. So getting to population immunity via just the virus, its normal sort of spread, is very dangerous and is something that we really can't do. And so vaccination is a safer path to population immunity. It's the alternative route that we have to population-based immunity. So let's talk a little bit about vaccines. So we've painted the picture now why it's important to get population immunity, and the two routes, one by spreading the virus, one by vaccination. And let's talk about vaccination. So vaccines are not a new thing. They've been around for about 200 years. The first vaccine that was used was against a disease called smallpox. And smallpox was a devastating disease in the 1800s. If you got smallpox at that time, you had a 20% chance of death. Remember, death from COVID is around 2%, and look at the devastation. So if you were an adult with smallpox, 20% chance of death. And if you were a baby with smallpox, 8 out of 10 of those babies would die. A doctor called Dr. Jenner noted then that women who were milking the cows and got a condition called cowpox, very similar but not as deadly, would never get smallpox. And what he did is he took a little bit of the fluid from the smallpox blister and injected it into a child. And that child's family developed smallpox, but he didn't. And that was really the first time that we realized that exposing the body to a milder form of something that looks like a virus could strengthen the body to prevent the severe disease. And then in the next 200 years, we have developed lots of vaccines. I always ask when I do a community training if anyone in the room has had a vaccine. No one puts their hands up. But I can guarantee you that you've had a vaccine, because when you were a child, you were vaccinated against TB with BCG, against measles, mumps, rubella, hepatitis, rabies, meningococcus. If you've traveled outside of the country to certain places, you'd have had a yellow fever vaccine. There are diseases on this list that I have, as a doctor, have never seen. I've never seen someone with diphtheria or whooping cough. I've never seen someone with polio. And about 50 years ago, these diseases were raging through our communities, even severe measles causing pneumonia. We don't really see that as doctors anymore. And that is the success of vaccination. Vaccines are actually so successful that we almost don't see their impact anymore. So children get several doses of different vaccines. The WHO estimates about 1 billion children have been vaccinated in the last decade, and it saves about 3 million lives a year. So vaccination is part of our lives. It's part of our public health policy and programs, and it's something that generally, as a population, we have accepted. Mothers and fathers take their children to the clinic and they are vaccinated. There are some diseases we don't have a vaccine against that's effective yet. For example, malaria and HIV, and we know the TB vaccine doesn't work well, and there are immune reasons for that. But basically, vaccines are very effective and save many, many lives. So let's talk a little bit now about how the vaccines actually work in our body. And I think it's important for us to have a sense of the science and the medicine behind this. So I'm going to use COVID-19 as the example, but this can apply to any virus, any bacteria that comes into the body. So what happens when COVID comes into the body? Usually COVID enters through the nose and mouth. We breathe it in, sometimes through the eyes, but generally we breathe it in. When we breathe it in, it gets into the fluids in the body, but it isn't yet in the cells. So the cells of your body are the things that make our bodies what they are. We have millions of cells in the body. And for a virus to make you sick, it actually needs to get into the cell. But to get into the cell, it needs to have an anchor or a lead point to connect it to the cell so it can enter in. And in the case of COVID-19, that thing that it uses to get in is called the spike protein. So this is the spike protein. And you'd have read a lot about the spike protein in the last couple of weeks. So the spike protein gives the coronavirus that look of the little crown, these little spikes, and it looks like this. The spike protein is used by the COVID virus to stick onto the outside of the cell and enter the cell. Once the virus enters the cell, it goes to the protein-making factory of the cell, and it hijacks that machinery. It hijacks the machinery to make more of itself, and it multiplies itself over and over and over again until the body cell is full of virus, sometimes up to 1 million viruses. And then the cell bursts open, and each of those viruses can then go use the spike protein, stick onto another cell, get into the cell, hijack the protein factory, and make more of itself. So within a space of hours and days, the virus can make millions of copies of itself and cause the illness that we see in COVID, which mainly affects the lungs. But the body is not just standing by while this is happening. The body is also responding to this infection because we have within our bodies a defense system, which is called the immune system. And the defense system has got general cells or general soldiers, which are always floating around looking for any danger and looking for any bacteria or viruses. So when COVID comes in as a virus, these general immune cells notice something dangerous and they swallow it up. The cell swallows it up and it kills the virus within the cell, which is great. But that's just one virus and one cell. So it's a quick process, but it is not very effective because it doesn't affect many, many viruses. So at the same time that the cell destroys the virus, our general soldier, it also takes a part of the virus to a specialized antibody making cell. And this part that it takes in COVID is the spike protein. It takes the spike protein to the special antibody making cell, and it shows that special cell, this is what a COVID virus looks like. The antibody making cell then makes hundreds of thousands of antibodies. This little blue thing here represents an antibody. What's special about the antibody is that it's an antibody which is specifically made against the spike protein. So it fits against the spike protein like a lock and a key, and it blocks the spike protein. It covers the whole virus, and it stops the virus from sticking onto our cells, and it stops it from entering our cells. And remember, if it can't get into the cells, it can't make us sick. At the same time, our immune system makes memory cells so that we remember how to make these antibodies later on. So that's how the body responds to COVID. And that's why some people get better from COVID and some people don't. It depends on the strength of their immune response. The only problem with an antibody response is that it takes days to weeks before you can generate enough antibodies to defeat the virus. So if you have a strong, quick immune system, you can make your antibodies early and defeat the virus. If your immune system doesn't respond well, by the time you have antibodies, your system is already overwhelmed. So what does a vaccine do in terms of all of this? A vaccine teaches our immune system, our defense system, how to make antibodies against COVID-19 before we have been infected by the virus. And if all you remember about this is that one sentence, that's absolutely fine. So inside the vaccine, which I've received and thousands of health workers in the country, is something that looks like the spike protein. It's not the virus. It's either the spike protein itself, or it's the recipe for your body to make the spike protein, just the spike protein. Remember, the spike protein is the part that's recognized as dangerous. Your body doesn't know this is a virus, so it responds to the spike protein in the same way. It makes antibodies against the spike protein. It floods the body with antibodies, and it makes memory cells. So what happens now is that your body has been primed and trained to make specific antibodies to COVID-19. When the virus tries to enter your body, those antibodies immediately block it by blocking the spike protein. That is the basic science of all vaccines and how they work. Okay, so normally now I'd have a chat and we'd talk about it, but okay, this is Zoom online, so we'll see. Okay, so that's the science of how vaccines work. Now, how are vaccines developed? So most people I talk to are really worried about the speed of the vaccine development and how the trials are done. And we're in an age now where we all have to have a handle on some of this science. So let's go through some of it. So when any drug is being developed, it has to go through a number of phases of trials. It's not just one trial that's done. Right at the beginning, someone has an idea. They have to test it, usually in a lab or on animals, and that is called a preclinical trial. So it's right at the beginning. That's to test the idea, is this going to work or not? Once the preclinical trial comes back with a positive response and it looks like it's working, then we move to testing it on people. It's called a phase 1 trial. But the phase 1 trial is just a few people, kind of 50, 60 people, under 100, and it's usually young, healthy volunteers. And that's just to check that if we inject people with this particular agent, they're going to be fine. So it's a safety check, the phase 1. If the vaccine passes phase 1, it goes to phase 2. Phase 2 is really about, okay, it's safe, it works in the lab, but does it actually work on real people? So phase 2 is a few hundred people. And essentially they give the jab and they see if people are okay, and also whether people produce antibodies. That's how they're measuring whether the vaccine is working. And only once phase 2 is complete do we then get to phase 3. So phase 3 is most of the trials you hear about. By the time we as a general public hear about a drug, it's usually in phase 3. Phase 3 is thousands of people, and here they're checking, okay, is it really safe and is it really effective when we give it to a big number of people? Now, most vaccines take about 10 years to get through preclinical phase 1, phase 2, phase 3. But we know that the COVID vaccines were developed in 1 year. And many people ask, how is that possible? Surely there's a problem here. But they're actually very good. I asked that question as well. I was wondering about it, but I am satisfied having read and spoken to people that it was done properly. So these are the reasons why the vaccines for COVID were developed so fast. The first reason is probably one of the most important. It takes a lot of money to make new drugs. You need to get sponsorship, you need to have a university, and you need to sponsor each phase of your trial. With COVID, there was massive, massive public and private investment in vaccine development. The US government, the German government, and the UK, the people just poured money into this thing, and they told the scientists, pause whatever you're doing, please help with this particular issue. So money was not a problem. The second thing is that this is not the first coronavirus that we've had as a population to deal with. We've recently had SARS and MERS. Those are both coronaviruses that we've produced vaccines against. So we had that technology already. And then Ebola, which is not a coronavirus, but it's a recent one as well. We developed technology to develop an Ebola vaccine. So the vaccine science in recent years was growing very quickly to deal with these viruses. So when this new COVID came, we had that as a basis to start working from. We weren't starting from scratch. The third reason we could develop the vaccine so quickly was that usually the bureaucracy in these things take forever. So you first have to publish your study, then you have to get registration, and it's long, and committees meet every 3 months or 6 months. But with COVID, because it was prioritized by everybody, universities, governments, regulatory authorities, registration was done very quickly. And they also allowed the companies to overlap the phases, which we can talk a little bit about if anyone's curious. And then the last point I find quite interesting is that the pandemic itself allowed the development to happen quickly because, first of all, people were tending to work together. Almost everybody now knows someone who's died or been sick or been in ICU or hospital with COVID. I don't know anybody who's not been affected by this thing. So think of the scientists working in this field. If you're a person who's developing vaccines, you feel this weight of responsibility, and people were really working hard and working together. The second thing is that when you have a virus that's spreading really quickly, it allows the study results to be gathered faster, because to test if it works, you have to see whether people are prevented from getting COVID or not. So if you have a lot of people getting COVID, you can see quickly whether this vaccine is working. So the actual fact of a massive pandemic helped with the speed. And then the last one is that many people volunteered for the trials. A lot of drug trials struggle to get healthy volunteers, and many people put up their hand as an act of solidarity and went in for the trials. You know, people don't get paid huge sums of money to be in trials. They're allowed to be paid for transport and maybe stipend for the day, but you can't be paid to give your body to a trial. You can't. It's unethical. So these were people volunteering out of the goodness of their hearts. Okay, so that's the process. We started with about 290 vaccine candidates, people that were trying different things from phase 1, and only 7 of that 290 have come through to the end. Also very reassuring. We didn't pick the first one out of the hat. Only 7 have come through to the end, and you will know these names: Pfizer, Moderna, AstraZeneca, J&J, Novavax, Sputnik, and Sinovac. In a few weeks' time, we may have 1 or 2 more, but that's where we are right now. Okay, how am I doing for time? Okay, so I think it's really useful. I'm going to show you 2 vaccines. And Ntsiki, just tell me how I'm doing if you need me to stop. But I'm going to show you 2 vaccines because, are we fine? Okay, I'm going to show you AstraZeneca and J&J. Sorry?
Before you get started, Lydia, there's just one question about
Sure.
if 7 have completed phase 3 trials, what happened to the other 290?
Yeah, it's a good question. And actually, I'm happy to stop. So if there are questions as we go. So some of them just get discarded and paused. This is why drug development is expensive. Some of them are still in process, so they're not all the way through. But if a trial fails phase 1 or phase 2, it gets thrown out. There's nothing else that we can do. If it doesn't pass, it doesn't pass. So many of them have been abandoned. For example, Merck has actually a couple of vaccine candidates that were unsuccessful, and that's just money that they've lost. Yeah, so they just get discarded. But some are still in process, so more will come through. Okay, it's really useful to understand how the trials were done so that we can interrogate the vaccines that come through. So South Africa at the moment has got agreement with J&J and with Pfizer, and then we had AstraZeneca. So once the vaccine arrives and lands, it's good for us to know a few things about how it was developed. So question to ask first, where was it done? So AstraZeneca, also called Covishield, was trialed in the UK, Brazil, and South Africa. They had 11,000 people, and those were all volunteers. And the way the trial works is you take the 11,000 people, each person that comes through, you put them into one of 2 groups. they're either going to go in the group that gets the vaccine, or they go into the group that does not get vaccine, which is the placebo group. You then register them, take all their details, and you send people out and they go and live their lives normally. And you monitor the two groups to see who gets COVID and who gets hospitalized. And then you get your results from there. It's actually as simple as that. The principles are quite straightforward. So with AstraZeneca, in the group that did not get a vaccine, 101 people developed COVID. The people that got the vaccine, 30 developed COVID. So that gives you the 70% effective rate. So it prevented 70% of cases of COVID, not 100, but 70%. The next important fact is how many people got very sick from COVID in the two groups. And in those that did not have the vaccine, there were 10 hospitalized with severe COVID and 1 death. And in those that received the vaccine, no one was hospitalized and there were no deaths. So that's why even though Covishield, AstraZeneca didn't sound that great, only 70%, the prevention of severe disease was high enough for us to feel that it was a good enough vaccine to use. We should also always check and interrogate the adverse reactions or the side effects of the vaccine and see whether they're more or less the same between the two groups. Something important when you're reading adverse events. So after the vaccine is administered or the placebo, those people are followed up closely. Anything that happens to those people in the trial period is written down. So if you have a myocardial infarction, if you have appendicitis, if you break your ankle, if you run over by a car, every single thing is recorded and is recorded as an adverse event. And then they check whether they're more or less the same between the two groups because they were randomly selected. And if it stands out like, oh, wow, there were 250 in the vaccine group and only 150 in the placebo, then they start to hunt. What's the reason? What's going on? And there may also be some adverse events which are more likely linked to the vaccine, like an inflammatory type of process or a neurological, and then they will go and have a special independent team that looks at those specific events to see whether or not they were linked to the vaccine. AstraZeneca was safe. They didn't find any adverse events that were directly linked to the vaccine. That is different to side effects. So side effects is what happens and is predictable almost after you get a vaccination. So after you get a vaccination, if you remember, I don't know if any of you are parents, when you take your child to the clinic and they get a vaccine, the clinic sister will often say to you, baby may have a temperature, they may be a bit irritable, they may cry, they may have redness in the arm. Those are predictable side effects from the vaccine, and it's your body mounting an immune response to the vaccine. And those are very, very, very common. And basically, they're the ones that I've mentioned with a bit of fever, headache. I'll talk a bit more about my personal experience with J&J, which is relevant. But so that was AstraZeneca. But as you know, when we tested AstraZeneca specifically against the South African variant, it was not effective. But the take home was, it's a safe vaccine, but it's not an effective vaccine against our particular variant. So that's why we are now using J&J. I'll just go through this quickly because you've got the principles. J&J, many more people, 43,000 people in the trial versus 11,000. So it was a big study. It was Brazil, South Africa, and the US, and a few other Latin American countries. And I just want to take you down to this part in red. So South Africa, number of people who got COVID, mild to moderate COVID, who did not receive the vaccine, 154. Those that received the vaccine, 66, which gave us a rate of 64% effective. We've heard 57 reported and 64. It's 64% now from the FDA data. And then very interestingly, against severe COVID, South Africa was even against our variant, 81% effective, a little bit less, but still very effective against severe COVID. And look at this, COVID deaths, 7 in the placebo group, 0 in the vaccine group. So this might be 100% effective for preventing death and very, very effective for severe disease. There were no safety concerns at all. Allergy is always something that you need to think about with vaccines, and about 1 to 2 per million allergic reactions are expected with any vaccine. So when I received the J&J vaccine, I was very fortunate to be on the first day as one of the health workers at my hospital. I got the vaccine on a Wednesday afternoon, and I was fine that evening. But the next morning, I woke up with a little bit of pain in my arm. I had a mild headache and I felt a bit nauseous. And the whole day, I just felt off, like just tired and a bit weak and a bit achy. But I went to work, had a relatively normal day. I came home and I slept early that night. And I woke up on Friday morning completely fine, feeling absolutely okay. I had the ache in my arm for another 2 days, and then that also went away completely. So I had some reaction, but it wasn't severe. Some of my colleagues felt absolutely nothing, which doesn't mean it's not working. It just means they just didn't react in the same way. And some people were quite sick for the first 2 days. So some people had a headache. They couldn't come to work. Some people woke up that night with a headache. A few people had diarrhea and some nausea. Everybody was better after 2 to 3 days that I know of and that I spoke to of my colleagues around me. And they've been absolutely fine since then. So it's short-lived, sometimes mild, sometimes it can be quite uncomfortable, but it goes away after 2 to 3 days. I just wanted to show you this map because we've talked about the South African vaccine rollouts received a lot of attention. So on the 17th of February, the day that we started our vaccination, this was a map of the world. Now, equity and vaccines is a whole other talk we don't have time for. But it was really a startling picture to look at. This is from Bloomberg. It shows the number of people per 100 vaccinated per country. Dark green is more people vaccinated, light green is less. And where there is no green, there is no vaccine. So if you look at our continent, it is really a devastating picture. Sub-Saharan Africa, nothing, not a single vaccine by the middle of February. And you can see how many millions of doses were given elsewhere. We know we had a rocky start to our vaccine program. And when the day that AstraZeneca landed in South Africa is the same day that we found out that it didn't work against our variant. I mean, that wasn't government's fault. That was just really bad luck. And it was good that we found out before we delivered the vaccine to people. And luckily at that time, just about that time, J&J was ready. The phase 3 was just finishing and they were ready to release their results. And because we had a big group of South Africans in the J&J trial and the chair of our MRCs in the J&J study, people pushed very hard to get doses of J&J vaccine so that our rollout could at least start. But it takes quite a long time to get emergency authorization for any drug. 8 to 12 weeks. And even though J&J had started that process in America and here, it was not ready. And it was not going to be ready for the 17th of February. So as an alternative, this was registered under research conditions as an implementation study. An implementation study means everybody gets the vaccine, no one gets a placebo, and then we monitor in real world terms what that looks like over time. So that's really what's happened, and that's what the Sisonke trial is. And I'll just leave this as my last slide. This is what it looks like now. South Africa has 76,000 vaccines we've delivered. We're still quite far behind many other countries, but at least we have started. It's an implementation study. Technically, it's not a rollout, but I think that's really a technical difference. Yeah. So Ntsiki, I'm going to stop there. I've spoken a lot, and we'll take questions and take it from there. Thank you.
Thanks, Lydia. That was very, very useful, I thought. And I'm going to ask people if they have any questions now. Otherwise, what I think we should do is maybe go through what Marcus has to say. And then I want to tackle some of the myths out there around the vaccines particularly. So if there aren't any immediate questions, you can either raise your hand or type in the chat or unmute yourself, whatever works for you in the next minute. And then thereafter, we'll just ask Marcus to take us through his presentation about covering the vaccine rollouts and such like. Willie says, thank you, Lydia. This was very empowering and eye-opening. You actually gave me strength to go and get mine. That was Thank you, Willie. That's very nice. I'm sure Lydia will be able to share her slides. We'll find out. Otherwise, we'll send them to you after this session. In that case, if we don't have any other questions, I'm going to hand over to Marcus. We don't have video, but we will be sharing your screen, Marcus, or at least Tumi will be sharing her screen.
Is the video working now?
Yeah, it is working now.
Cool. Hello, everybody. Thank you, Ntsiki, for inviting me, and thanks, Lydia, for an excellent presentation. I'll talk briefly about some of our experience at Spotlight. For those of you who don't know Spotlight, we do public interest health journalism. We're published by Section 27 and the Treatment Action Campaign, but we are editorially independent, and we're members of the Press Council. So we function like a normal journalistic entity. Now, so what I'm going to talk about today is some of our, I guess, lessons and our experience covering COVID and vaccines in particular. Keep in mind that, you know, we get to do health all the time, and I'm quite aware that those of you working in community journalism have different pressures. You may have less time to devote to health, so the dynamics may be different. So not everything I say might be as applicable to your situation, but I can only speak about what I know. So two broad framing ideas to start with, which we like to keep in mind, is that as our journalism has two functions. The one is to inform the public, and we inform the public with credible, accurate information so that they can make, or people can make decisions about their own health based on accurate information, and so that people can play their part in our democracy based on accurate information. So it's worth keeping that empowerment angle in mind. It's one half of what we do. The other half is accountability. And that is where we hold the state accountable for things like rolling out vaccines and making sure it works properly and there's no corruption, etc. So as I talk, keep those two ideas in mind. There's always a tension, a healthy tension between these two things: informing and empowering, kind of a developmental idea, and the hardcore accountability. So I'm going to go through 5 observations, kind of ideas that you can take or leave, but that we've found useful. So the first is kind of a basic idea that I think on any topic I encourage journalists to get back to, and that's the idea that good journalists read good journalism. Ntsiki will share some links in the chat, but this is one of the, I think, one of the kind of fundamentals of becoming good in a subject area, right? So if you want to do a lot of health reporting, and most of us are going to do a lot of health reporting for the next year at least, probably more, 2 or 3, then it's good to have a solid grounding of what other people are doing. So what I mean, for example, is that if we have difficulty in explaining or coming to terms with vaccine skepticism in our reporting, then there are examples from all over the world that we can look at to see how other journalists have dealt with that. If we have difficulty in explaining complex terms, then other journalists all around the world would have struggled with the same issues. So by reading widely, you get a sense of how other people solve the same problems we have in explaining complex issues. And you also get a good idea of what questions to ask. Now, the kind of things to read Some of it is technical, so it might not be applicable to everyone, but I'd encourage people to look at Nature. It's a scientific journal, and Science. These are two journals that have some technical information, but they also do some very nice, easy to follow kind of summary articles that give you the lowdown on adverse events with vaccines, for example. Nature had a very nice article on that a while ago. So what I do is I check those sites every week. And then obviously other medical journals like the British Medical Journal, etc. That stuff might be too technical for some people. You might not have time for that. It's also worth looking at kind of more accessible work. The New York Times has done excellent explainers. The Atlantic is a pretty good US-based publication that has they've made all their COVID-19 stuff free, so you can access that. And there are obviously lots of local examples as well. So this is kind of an odd point to start on, but I think it's reading good journalism is the nourishment that will make the rest of your work better. So I encourage people to do that. So the second point I wanted to make is about language. And our kind of principle at Spotlight is that we always assume our readers are intelligent, readers or listeners, I suppose, but we also assume that they don't understand the jargon. So there's a interesting balance there that we want to make what we write accessible so that everyone can understand it, but we don't want to dumb it down. We don't want to make it so simple that we're talking down to people. And we believe this can be done. So this is essentially an essential part of what we mean by good science journalism, is that you can explain things, complex things, and things that normal people can terms that normal people can understand. So what this means in practice is when you speak to an expert and you don't understand a term, we ask, what can you explain that in lay language? Do you have a metaphor that we can use to explain this? I find metaphors are very useful. So that is something we pay a lot of attention to. If you don't understand it, your reader won't understand it. And especially numbers are worth interrogating. If you say a vaccine is 60% effective, then you need to ask, what does that 60% mean? Like Lydia explains, this can be effective against moderate disease, but that's different from efficacy against severe disease and efficacy against death. So whenever you have percentages in your reporting, it's worth asking, what exactly does this percentage mean? And that's all part of making your reporting more accessible. Then our third point is that it's, as far as possible, we like to go to the original source of information. So with COVID-19, that's often been sources like the NICD, the National Institutes for Communicable Diseases. If you don't know their website, I encourage people to look at that. They have a section, a coronavirus section. In the coronavirus section, they have the guidelines, so you can see what guidelines people are using to treat, what to diagnose, etc. There's a section on surveillance reports, which is extremely useful. You'll find reports there on things like hospitalization, how many people are going to hospital, testing. And one of the useful things about these reports that they publish is that a lot of the information is broken down by province, and some of it is broken down by district or metro, so you can see what's happening in your city. And often it's hard to find that information, so that's why we're sharing. The NICD makes a lot of that stuff available. And rather than quoting some other source or someone who said something, we think it's better to go directly to these documents and say, this is what the NICD is reporting for our area. There are some other great sources. We'll share the links. The South African COVID-19 Modeling Consortium did a very nice website, also with some district level data on deaths. There's, as Lydia explained earlier, there's the official count, but it's also worth, what we do every week is we check the Medical Research Council's latest mortality report. And that report tells you how many excess deaths we've seen. It shows you the trends. Also, it gives some detail by areas, so you know what's happening in your province or for your district. So, yeah, going on to the fourth point, one issue we've struggled with a bit is which experts to quote in our articles. So there's been some reporting, you know, where people who are not an expert in, for example, epidemiology, are given a platform to make comments on epidemiology. Now, our position is that that's not ideal. From a journalistic perspective, if we're doing something on vaccines, then we want to talk to experts in vaccines. If we are doing something about what's happening in ICUs, in emergency rooms and hospitals, then we want to speak to experts in emergency care. So we don't assume that being a medical doctor makes someone an expert on any specific field. We think it's better to talk to the people who are experts in that specialty. And that's kind of a shortcut to making sure that you inform your readers or listeners more accurately. Where to find these people, I think that's sometimes a challenge, but fortunately we have lots of experts in South Africa who are world-class researchers and are willing to give their time. So we often go to kind of respected scientists at people who head departments at our big universities, senior scientists at the NICD, for example, and senior scientists at the Medical Research Council. There's a risk that you keep going to the same people, but yeah, as a kind of rule of thumb, it's better to go to the people with who are kind of recognized as being leaders in their field. I think as journalists, there's, you know, our view is that if we give a platform to people who are not experts, then we're not fulfilling our role of informing our readers accurately. So yeah, that's that. And then the last point I want to make is about accountability. So most of what I've said so far is about making sure our journalism is accurate, it informs the public, it's accessible, it gets accurate information across. The other side is accountability. And with the rollout of vaccines, this is going to be a big issue. What happens in your city, in your town? Who's responsible? And there, I think the key thing that I would stress to journalists is that our healthcare system is devolved to provinces. So our National Department of Health makes policy decision, they're handling procurement of vaccines, but the actual responsibility for the vaccine rollout in your city or town, that is down to your provincial health department. So the people you must ask questions to is your MEC for health, the head of the health department, possibly the district health manager in your area. So that's where the accountability lies with that. And I would encourage people to really push hard on that. doesn't have to be confrontational. The first obligation on the state is to be transparent. So they must tell us when or how vaccinations are going to happen, where. It might, well, for now it's still too early to say exactly when, given that we only have the implementation study so far, but when the proper rollout begins, those plans need to be public, and its provinces need to be public with those plans. So we've seen some things being presented in Parliament. It's been very sketchy so far, and I would encourage people to report on that in your local area. And then obviously if things go wrong, then we should ask questions as well. So I'll stop there. I'm also happy to take questions. Thank you.
Thanks, Marcus. I think that the information around district level and provincial level interactions with the government is hugely important, because we focus a lot on what national government has to say. But for people who are working in the community, we need to be able to access the people who are directly responsible for the delivery, particularly of healthcare. So that was really useful input. Thank you very much for that, Marcus. Are there any other questions? Are there any misinformation you've seen in the media, social media, and elsewhere regarding the vaccine, asks Melissa. We've gathered a few questions around basically what we've noticed, and so I'm going to be posing them to you, Marcus, and to you, Lydia, just to see if you can help us answer these questions. For example, does getting the vaccine guarantee that you won't get COVID-19 and pass it on? Can I ask you to do that, to answer that for us, Lydia?
Thanks. Sorry. Yeah, no, that's a very good question. No, it doesn't guarantee that you won't get COVID and that you won't pass it on. So no vaccines in the world are 100% effective. So for them to guarantee that you don't get COVID, you would need to be seeing percentages of 100% effective. And of all the reports we've seen, we've never seen 100% effective. The best we have is the Pfizer and Moderna, which is 95% effective. And the J&J vaccine, as I've shown just now, is only 64% effective against getting COVID. That's having the symptoms of COVID. So you can still get COVID if you've had the vaccine. The main advantage of the COVID vaccines is that if you do get, you have a smaller chance of getting COVID. So your chance of getting COVID is 64% less with this vaccine. And also your chance of getting severe COVID is 80% less, and your chance of dying with the information we have is 100% down. So that 100% may change over time as we do bigger and bigger numbers, because you'll see there were 7 deaths in one group and 0 in the other. But from the information we have now, it's almost 100% prevention of death, 80% prevention of severe disease. But yes, you can still get COVID. Can you pass it on? Yes. There's still a lot of information that is being developed around this asymptomatic COVID and how much the vaccines prevent asymptomatic and can you still pass it on. But at the moment, even if you've been vaccinated, you still need to wear a mask, wash hands, and prevent transmission to other people. So for example, for me, I've been vaccinated. After a month, I will have the effects of the vaccine in my body. So that's also important to say. It takes about 28 days. All these trial results are after 28 days. But I still have to be careful when I'm with my mom. I can't just take off everything and behave in a normal way. So what I still have to do is wear my mask and so on when I'm around other people to protect them. And when I'm in the hospital, I still need to wear my PPE until everybody has got the same level of protection.
Great. So, I mean, that also just brings me to another question. How long does the vaccine last? And will people need to be vaccinated every year like we do with the flu?
So there's so many things in COVID we don't know for sure. So this is one of them. We don't actually know for sure. You'll see lots of reports coming out about antibody levels coming down or antibody levels staying up. When I've listened to Shabir Mahdi, and Marcus is absolutely right about this, If you're asking about specific, if you want to report on a vaccine thing, you ask vaccine developers and specialists in that field. So he says that most coronaviruses, the immunity lasts, so other ones like the common cold, 18 to 24 months. We don't know how long these vaccines will give immunity because we haven't used them for long enough. So the first vaccine was given in December last year. From the trials so far, we're looking at least 8 to 9 months, but it is probable that there will need to be boosters. No one knows for sure. We will get one vaccine and that will cover us for life.
I'm not unmuted, sorry. Marcus, a question for you. Sue was saying, just to clarify, the same company that produces ivermectin has also been working on a vaccine for COVID. Are they trying again to produce another successful vaccine? Do we know anything about that? That's news to me. Marcus?
Yeah,
Any
well, I don't, I mean, I know that ivermectin is made by many different companies, so I'm not sure which specific company is being referred to, but as Lydia pointed out earlier, there are, I mean, lots of vaccines in development, and it remains to be seen which ones of those work.
We'll watch that space. Another question through on the chat says, will pregnant women who have serious comorbidities be allowed to take the vaccine? That's a difficult one.
Trials usually studies don't usually include children and pregnant women because they're more vulnerable groups. And it's only once the first safety data is out that we then extend it to, so at the moment, pregnancy is what we call a relative contraindication. So we don't have information about safety in pregnancy. So at the moment, we can't strongly recommend vaccination in pregnancy. I know that in some places in the UK, they've been measuring the risk for individual women who are pregnant and saying, look, risk of your COVID versus the risk in terms of pregnancy, and some women are being vaccinated, but at the moment, we're not offering it to pregnant women. Serious comorbidities, yes, the vaccine is being offered to people with serious, I don't know if those are two separate groups they're asking the question, but the vaccine is being offered to people with serious comorbidities. They are the particular group that are at high risk. Yeah.
I've seen that. Another question here is, in the graph, Lydia, you shared about the global vaccination progress. Will travel be restricted for people coming from countries that have not had major progress in vaccination?
Well, you know, we're already restricted. No, I mean, you know, who knows how those global dynamics, that could be politics and geopower dynamics, will play out. We are already restricted in many countries because of the variant in South Africa. I think that the failure to have equity and access to vaccination throughout the world threatens the success of the vaccination program in every country. So if the US successfully vaccinates its population in 6 months, which they think they will achieve, but they allow or have rules or trade regulations or patent rules which restrict access to low and middle income countries and allow the virus to rage unchecked in those countries, new variants will be created, which will threaten the immunity of their populations they have vaccinated. So I suppose the answer is probably yes, I don't know for sure, but I think it's going to have a major impact on how we move around in the world, and the sort of insanity of not ensuring that everyone is safe is really being highlighted by this process.
Most definitely. I mean, the UNAIDS, head of UNAIDS called it a vaccine apartheid, you know, denying people access to vaccines, because until we're all vaccinated, no one is safe. And as you say, variants could spring up that make it difficult for us to get to population immunity around the world. Another question was, what does the recent announcement about the SA variant mean in terms of vaccine development in South Africa's approach? I think that that question is referring to, you know, the efficacy of the vaccines that are available now, and then which ones we're going to buy.
Yeah, I think it's a major blow. that we have a variant anywhere in the world that has demonstrated that it can escape the vaccine immunity. We don't really know yet for AstraZeneca, which is the vaccine that was tested here, which was shown not to work for moderate disease. We don't know whether that vaccine would have worked well for severe disease. The reason we don't know that is that it was a small group of people and they were all quite young, and nobody in either group, either placebo or vaccine, got very sick. So we don't know whether the vaccine would have made a difference, but it's quite a big gamble to vaccinate people when you don't know that. So the existence of a variant that is resistant to the vaccine has major implications for how we plan our vaccine rollout. It's going to make it more complicated because we have to ask the question for each vaccine, not only how much does it cost, can we get it in, how much can we get here, but also is it going to work against our variant. At the moment, only 2 vaccines, to my knowledge, have been tested here that have completed phase 3, and that's J&J and AstraZeneca. So even Pfizer, Moderna, Sputnik, the other really good or very efficacious that work really well, those good vaccines, we don't know how they will work in the South African context against this particular variant. So it throws a whole level of complexity into our rollout, which at the moment other countries don't have. I don't know why we can't cut a break sometimes as a country.
Tell you, I mean, this is the thing. So one of the things that we keep coming up against, and I'm sure people who are attending this webinar will come up against, is how do we trust that the government is going to do everything to make sure that the population is protected? Because I mean, I believe that they're doing everything that they possibly can, but you know, there've been fumbles. So it's not something that I'm expecting that you'll be able to answer as a medical professional or even somebody who works for government, but it's, yeah.
Yeah, I mean, look, the work we need to do on vaccines is, there are 2 parts to it. The one is empowering people to make an informed choice about accepting a vaccine. So this kind of work that you're doing now, which is important for confidence in the scientific process. And the other part of it is navigating the complex political field of vaccine access. And in the South African context, we have strengths. So we have a functional public health system, weak in many places, but we have quite strong academic centers and university-based hospitals in urban areas. We have a big health workforce, very skilled health workforce in public and private. And we have a strong scientific community. So we have got things going for us. We also actually have money, you know, we just need to spend it properly. And then on the other side, and we also have strong communities and strong voices and activists. On the other side, we know all of the weaknesses that we have, corruption and incompetence and inefficiency and so on. So we have to find a way as civil societies to strengthen the strong aspects and to hold accountability at local, as you were saying, Marcus, local, provincial and national level. I think that the fact that we have a lot of scientific debate in the country is good. And I trust what's coming out of the NICD and the MRC. I think we've got authentic and genuine people working in those parts of the country and our structures, and SAPRA included. We do need to watch the political speak and the spin around it and make sure that we hold that.
We'll hold them accountable. Do you want to weigh in, Marcus?
Yeah, I mean, I would say from a journalistic perspective, I think we should have high expectations of government. You know, we should not be lulled into accepting that because transparency has in some respects been poor, that's a justification for it to remain poor. So in our questions, in our interactions with all spheres of government, we should expect transparency. We should expect them to be efficient and to have good vaccination rollout plans at local level. And if they don't, then that's something we report on. But our starting point should be to expect things to work properly. I just think
to not be afraid to challenge them when they don't.
Yeah, exactly. I mean, there's a fine balance between being confrontational, which I think is often counterproductive, in our politics. If as a journalist you're seen as always being critical, then things get harder. But I think the public in general appreciates it when journalists stand up for our basic constitutional rights to. That includes transparency of procurement, the right to healthcare, etc.
Agreed. So as an adjunct to you, Marcus, one of the people in the chat are asking, how do we as media counter anti-vaccine campaigners?
So that's a very good question. We did a spotlight together with Ground Up News, did a long Q&A that's we're updating from time to time on vaccine information. That's one way. Just keep publishing the correct information. It's often useful to address myths directly.
Yeah.
I think if you just disregard people and tell them it's crazy to think 5G causes COVID, then you might lose people. It's better to explain why that's not possible.
Yeah.
I guess the other kind of journalistically interesting thing here is that, we've been having this challenge in journalism for a long time that sometimes we make the mistake of writing he says, she says stories, where you pretend there's two equal sides to a story. Now, in the case of things like HIV denialism or vaccine skepticism, that is the wrong way to go about it, because if you present it as two equal sides, vaccines work and versus vaccines don't work, then you risk leaving your reader with an inaccurate impression that there's a debate about this. Whereas the truth is there is no debate. So, as journalists, we shouldn't take the idea of balance too far when writing about science. A more useful concept is something called due weight. So you give due weight to the different sides based on how credible the information is, based on the scientific evidence, etc. And with vaccines, that means by far the most weight should be given to what we know, the kind of things that Lydia just presented, the facts, what the studies tell us, etc.
Yeah, agreed. But because people are going to be encountering this in the community, I'm going to have to give some airtime to the myths now. Yeah. So we're going to look at a few. Here, when you talked about the 5G thing, and I see that I think it was GCIX actually put out information about the fact that there is absolutely no link between COVID-19 and 5G. So we won't even entertain that one. But there are others, like vaccines cause infertility. I mean, for me, that was a bit of a shocker. Lydia, are you able to give us an insight into, where that, how to deal with it?
So we tried to find out where this originated, because this myth emerged in January, where the vaccine had only really been administered, and it came out from a report in India. They'd only started their vaccine rollout a few weeks before. There's no way that you could have seen any impact on fertility in such a short time. So the vaccine doesn't, test impact on fertility, but there's no plausible explanation for how a vaccination that's stimulating your immune system could affect ovaries in any way. No other vaccine of the many vaccines that we use affects fertility at the moment. And the best reference I could find was the NHS-ONG Society, Obs and Gynae Society, published a statement on this, saying that they'd looked into it and there's no scientifically plausible explanation for how a vaccine could affect fertility. The difficulty with a myth like that is that you can't actually disprove it, because we haven't been using the vaccine for long enough, but there is no scientific basis to imagine that there would be a problem with fertility. It links in a little bit to the Bill Gates myth that fertility is being controlled because we want to control the world population. So that's how I've heard that myth coming together. But when I sort of have explained that there's no way that we could have assessed impact on fertility in such a short time, people are like, oh yeah, that's true, you know, because it's kind of, we just started vaccinating, and vaccination there's no scientific basis for it affecting your ovarian function at all. I don't know if that helps. I'm happy to send you that link of that article so you can put it on your site as well.
That would be great. Thank you. Yeah, and it's very clear. Like, as you say, we don't have enough scientific data to make that assertion at all. The other question around, I hate to give credence to these kinds of things, but they're saying the vaccination program aims to inject tracking devices into people so the government will be able to monitor people's personal lives. How do we even start to answer that?
Yeah, I find those ones more difficult. I mean, there is a myth about the vaccine changing your DNA, which comes from the mRNA issue. And that one we can address because you can explain that mRNA is used to message that the vaccine gives to make the protein. But the mRNA is very fragile. And once it transmits its message, it disintegrates and it doesn't enter into the nucleus of the cell where our actual DNA sits. So that myth you can actually talk through some, because they're using some factual basis. So RNA is connected to DNA in some way, but the DNA is not, it's not DNA and it's not integrating into our cells. But something like the microchip is very difficult myth to deal with because it's impossible for there to be a microchip. It's a 0.25 moles of fluid that's injected. It's see-through, you can see through it. And there's no chip that's microscopic that you can't see that you can inject into a person. So the tracking devices that are used, for example, in animals, they have those little chips. You can actually see them. So that would be the only thing that I could say, that it's a tiny amount of fluid which is completely see-through. And the political justification for tracking, we'd really need to unpack the logic behind it. Yeah, I'll let you see if there are any other.
There's not many more here, so I actually would like to ask people to let us know if there's any that they've encountered in their communities that we can ask Lydia or Marcus to address here. There was a question about the 501 variant, which
yeah, I saw that question. Interesting question about the fact that we're showing that there is neutralizing, that people who've had the South African variant of COVID and recovered, they are immune to other variants, so the preceding variants, which is positive news. And yes, I'm sure that will be integrated into vaccine development. Exactly how that will be done and how long it will take, I don't know. But it is a hopeful thing, because it means that we are able to, if we can find a vaccine that can impact on many parts of the virus, produce immunity to many parts, that's another option. Or this one of looking at immunity to this particular variant and using that information to develop a better vaccine. Basically, the vaccine community, the vaccine making community, is going to have to constantly recalibrate in the face of these variants and make new versions. On the positive side, once you have a vaccine that works, it's not as difficult to change it against a new variant, but it does take time. So it can't be done, you know, in the space of days. It's going to take months to test and so on. Just on the myth and hesitancy in general, I think it was useful for me when I heard someone explain that there's a difference between sort of vaccine denialism and vaccine hesitancy. And my sense is there's quite a lot of hesitancy in South Africa, but there are not a lot of people I've encountered who are outright, I don't use any vaccines, I don't believe in vaccines, I don't want to alter my body, I want my body to be pure. That seems to be quite a small subset of people. The majority of people are just worried by all the noise. They're worried about the speed of the production. They're worried about safety. And that's where I think we need to target our information campaigns. So not to take head on going into a full front battle with real vaccine denialists, but rather speaking to the general population who just like, there's so much information and I'm confused, and just actually have the respect to empower them with information that they can use to make an informed choice. And also to emphasize that it is voluntary. The vaccine is voluntary. Nobody can force you to take this vaccine. We can encourage you, but it's your right to refuse. I would also say it's your right to make an informed choice when you refuse. So don't just say no, but it's your right to have the information to understand the implications of your decision.
Precisely. I think that that's why we've embarked on this, and what we're going to be taking forward into our campaign is that people must have an informed choice. And that for me, the decider is whether or not we're able to connect with people again in future. And so we have to continue to do social distancing and avoiding crowds and wearing masks and sanitizing for the foreseeable future until we get herd immunity, population immunity, and getting a vaccine is going to get us sooner and with less collateral damage or deaths and poor people who are being affected. And so for me, that is the reason why we need to be doing the vaccination information and also convincing people that vaccination is good for them. If we have no other comments or questions.
There's a question from Bethel.
Bethel says, is it possible to have antibodies against coronavirus if you have never been infected? Good question.
So there are two parts to that question. The one is some of the antibody tests, there may be some cross reactivity, or they might pick up antibodies that look similar to the COVID-19 ones, but that might be from other coronaviruses. So that's a small percentage. But more commonly, what's been happening is people who've had COVID-19, but they've been asymptomatic. So they haven't had any symptoms. So they had the infection, but it passed through their system, who then later on go for an antibody check and they find that they have antibodies. That's probably what's happening there. So you have been infected by COVID-19, but you didn't get sick from it. And your body produced antibodies quietly in the background, did a good job. And now you have antibodies against the virus.
I mean, just while we're here, there was a question that came through all of the research that we've been doing about children and whether they are going to get vaccinated, and if not, why not?
So at the moment, the youngest age for any of the vaccines is 16 in the US for one of them, but generally it's over 18. So we're only vaccinating adults at this time. For two reasons. The main one is that it hasn't been tested on children. So vaccine or drug trials will always start with adults and not a vulnerable population, which is children. But they are starting to do some trials on children now that safety has been shown. So we need to wait for that information to come through. And the second part is obviously we know that children are not as severely affected by COVID-19. They do transmit it, but to a lesser extent. So the priority in the vaccination program is the high-risk groups and adults, and also safety hasn't been proven in children yet.
For me, I feel like we could continue asking questions for the rest of the afternoon, but we have 4 minutes left that we've allocated to this time. So I'd like to give our audience another opportunity to ask questions, post it in the chat or raise your hand. If not, I would like to thank you very much for giving us this time and for how simply and accessibly you've put the information. And we're hoping that people will take this forward into the community and help people understand how important it is to continue to behave safely, and also when the vaccine comes, to give it a serious think about having a vaccination. I don't know if Marcus has anything else to say, but I'd like to really thank you, Lydia, for your time. I really appreciate it.
Yeah, I would
Thanks
just
very much, Ntsiki.
Yeah.
Sorry,
I would just
Marcus, go
underline
ahead.
the last point you made, that from the journalism side, I think it's really useful to think of it as empowerment. That's what we're doing. doing all the work we do as journalists to get the information right, to make sure it's accurate, it's credible. And the reason we do it is because it empowers people to take control in an informed way. Thanks.
Great, thank you. Okay, one more post in the chat from Melissa, who says, people who go to clinics, how does it work to be vaccinated? Do they apply, or does the clinic select people?
Yeah, so the details aren't clear yet, Melissa, but the way it's working is that if you're in phase 1, which is where we are now, you register with the EVDS, which is the vaccination website, the national database. And then it's supposed to generate an appointment for you at your local clinic. With the health workers now, we've registered. The appointment process hasn't worked well. So we got our registration and our voucher, but we haven't really had the appointment. So you won't generally just be able to pitch up at the clinic. You will have to opt in. You'll have to register and say, I would like to be vaccinated. And then the system is supposed to give you an appointment and where you need to go to get it. Mm-hmm. So there's going to be quite a lot of information sharing needed around that process. And I suspect a lot of teething problems when it starts, just judging from how it's been with us in the phase.
Most definitely. There's a question here that says, what will happen for people who are not able to register on the website because of lack of access to technology? Yeah, it's going to be a thing. I mean, we can only take lessons from how the Department of Education has been running their registration program as well. So they have sites, as in libraries, or their actual offices where people are able to access terminals to be able to register. So I think that would be a solution. But Marcus, did you want to weigh in on that?
Yeah, I mean, this is exactly the kind of questions that we should be asking as journalists. And that's kind of what I meant earlier, that government needs to tell us how exactly this is going to work. And we need to know that sooner rather than later. And we need details exactly at local level, what happens to people if you can't access the internet.
Yeah, I mean, so in relation to the rollout, we're in phase 1 now, where the health workers are getting the vaccine. We're going to then go into phase 2, where those who have comorbidities and are at higher risk, so older people, will then get the vaccine, and then the rest of us. So I don't expect that we will see and we hope that as they go through the phases, the government will be working out the kinks, so that by the time we get to population level vaccinations, there's a clearer way of and we'll communicate the information as and when we get it as well. It is now 12:30. And so I'm going to say thank you very much to all of the people who joined us today. We hope that this has been really useful for you, and we'll make the resources, the presentation, the recording of this available to everyone who registered. And we will keep in touch with you as we go forward. As we get more information, we'll share. Thank you very, very much for coming through today. Thank you to our presenters, and have a wonderful day, everyone.
Thank you. Thanks very much. Thanks, Marcus. Thanks, Ntsiki.
Thank you. Thanks, Lydia.
And all those that called in. Thank you. Bye-bye.
Thank you, everybody. Bye-bye.